I mean, who in Mumbai is eating like an Italian, right? Like, it's good food, Italian food, but it's not Indian food. The real kind of difference I think I see in Indian and Indian subcontinent diets is the use of ghee. So lots of kind of high intensity fats that just lead to weight gain.
Another really interesting thing that's come out of that study is actually people from North India have more hypertension,
Right.
and whereas people from South India are more likely to have high cholesterol. So two people who are similar with some risk factors. One is Indian, one is white.
Yeah.
How does this risk stratifying tool, QRisk3,
And it will draw you a little picture. It basically is like a room, right? So it draws you a picture of a room with 100 people in, 100 nickels. 99 of the 100 nickels will be a little yellow smiley face. That's the 99 people that are not having a heart attack or stroke over the next decade. Now, if you didn't have the ethnic background or the kind of Indianness, 1% risk for one sad face, which is one sad Indian having a heart attack out of 100. It's two sad Indians having a heart attack out of 100.
I guess the assumption we're making is that they've seen a good doctor like yourself who has really... Welcome to another episode of Delhi Belly, a series of conversations around preventative health tailored to people of Indian origin. My name's Nikhil Alawalia. I'm a cardiologist and a researcher in cardiovascular disease.
I'm Abhishek Joshi. I'm a consultant cardiologist in London. It's lovely to be here back with you again in this lovely room.
So today we're going to be talking about differences of care and how a doctor will make a decision about when to treat risks and when not to, because there can be a lot of discrepancy in what different people are told about their health. So again, let's start off with another scenario. You're a 42-year-old IT professional who's got raised cholesterol, and he's got a little bit of high blood pressure when they go see the doctor. And his doctor tells him, you don't need to be on any medications, just manage this with exercise and lifestyle. Now, the funny thing is when he goes back to work, his colleague, who is a younger gentleman, who has got similar sort of risk factors to him, is already taking a statin and says, you should be on a statin as well. And both of them are confused. Who is right? Who is wrong? How were those decisions made? Is this all just random guesswork, or is there some sort of systems that people use to make these decisions?
Right. Yeah. What a great question. I wish I was 42. It'd be a really nice age to be. And this happens, right? Earlier on, we were talking about, in another episode, about getting your risks checked. So I'm really glad to see both of these guys have gone and get their cardiovascular risk checked. They've presumably gone to see their GP. They've got their blood pressure and cholesterol and their diabetes status checked. And then I guess it is really confusing when you come out from the same appointment, right, with two different doctors and two very similar people have the same outcome.
How would you approach that scenario if a patient came to you? What do you use for your decision making?
Okay, so that's a really great question. The first thing I want to do is get some real basics measured. So initially we'd take the blood pressure, make sure we do it properly, right? There's a really important set of techniques for taking blood pressure. It's got to be sitting down. It's got to be a kind of in a room. It's got to be calm. You take 3 measurements, that kind of thing. What you don't want to do is arrive for your appointment, right, that you're 10 minutes late for. And the first thing that happens is your blood pressure gets checked. And then you get treated for the blood pressure that's just the stress of being late for your appointment. Or like you don't want to barge into someone in the most important stressful meeting of their lives, check their blood pressure, and then say, we need to treat your blood pressure for this, because that's not what the data says. It's about calm and repeated blood pressure measurements.
Do it right.
Super important. Got to be done right. Then I get some blood tests done. So I definitely check the cholesterol. There are a bunch of different cholesterols. We maybe talk about that in another episode, but I focus in really carefully on cholesterol in my clinical practice. You want to know if you've got diabetes or not. That's on a couple of blood tests too. And then you can feed those sorts of pieces of information along with your sex and your age and some other demographic data, depending on which bit of the world you're in. Talk about that in a second, into a risk score calculator. So there are loads of these, loads of them. And their job, essentially they're bits of maths, they're bits of calculation, where all the things that we know about you go into a formula, and then the formula gives you a chance, a probability, or a risk rating of you having a heart attack or stroke over the next 10 years.
Fine, but we've spoken in previous episodes about how being Indian increases your risk. So just by being Indian, I have a higher risk. So on that checklist, surely that needs to be taken into consideration.
What an amazing point. Yeah, great question. So there is one risk score, one that we use in the UK actually, that does take into account ethnicity. That's called the QRisk3.
QRisk3, okay, fine.
Yeah, and QRisk in general.
I mean, do you know how many Indians were in the data set that derived that risk score?
No, I don't. I hope it's lots, because we use it and we modify the risk based on people's ethnicity. And how many?
That's based on 1.8% of the population there being of South Asian origin.
Okay, that's not a lot. It's pretty good work.
But you're saying
if you're going to build a risk score in the UK and you're including 1.8% of Indians, that's probably not representative of the number of Indians in the UK, right? Or people of Indian origin, at least.
Yeah, but you're saying the score still takes into account the fact that
Yes.
people from India are at a higher risk.
QRisk3 does. There are loads of other scores that people use. So the Europeans have got a score, which I think is called SCORE. The Americans have a bunch of scores. The original kind of Framingham score, which is from one town in America, is where all of this started. It's like the stuff of legends in cardiovascular. All of them will kind of give you a rough risk. So I suppose if you're having like a Framingham score, I don't know if people are still using Framingham in their practice. Maybe there's some people in India still using that, or there's some specific Indian scores.
Okay.
We'll talk about that in a minute. You need to know that that score was kind of generated in an American population or in a European population or a British population. And if you're Indian, and we know that the Western population have heart attacks at half the rate at a young age, you probably want to add a little modifier for the Indianness of the person coming to see you.
So what is that modifier? Let's change our scenario. So you've got two people who are similar with some risk factors. One is Indian, one is white.
Yeah.
How does this risk stratifying tool, QRisk3, differentiate between those two people?
Okay. Well, I mean, you can look it up yourself if you're interested. QRisk.org is where the risk stratifier is. GPs do this with you a lot, so they maybe show it to you in the appointment. I think it's an amazing score. I really like it. And what it does for you is it tells you your risk. And what we mean by risk is probability, right? So you type in your stuff into the score. So where do I live? How old am I? Have I got diabetes? Do I have atrial fibrillation, which is a condition you know a lot about, Nikhil? Have I got some other conditions? What's my blood pressure? That kind of thing. And it'll draw you a little picture. And it basically is like a room, right? So it draws you a picture of a room with 100 people in, 100 Nikhils.
Yeah.
And for you, I'm going to guess, because I don't know anything about your health, 99 of the 100 Nikhils will be a little yellow smiley face. You know the little smiley emoji?
Sure.
Because that's the 99 people that are not having a heart attack or stroke over the next decade. And then there'll be one sad little blue face in the corner just to represent that 1% risk. So if there were 100 of you, one of you might have a heart attack over the next decade.
Fine.
Now, if you didn't have the ethnic background or the kind of Indianness already factored in a little bit in QRisk.
Yeah.
So if it was just like ethnicity, it didn't know what your
Kind of
ethnicity
Framingham
was.
score,
Yeah, exactly.
another
Like Framingham score, something like that. You might have maybe an extra half or an extra one sad face in the room, right? So instead of there being a 1% risk for one sad face, which is one sad Indian having a heart attack out of 100, it's two sad Indians having a heart attack out of 100. Now, you don't want to be that sad blue face, right? You want to maximize your chances of avoiding a heart attack. And that's what these scores are for. They're not just for saying, well, good luck. 20% of the people just like you are going to have a heart attack over the next decade. Many of the things you measure are modifiable. So you can control your blood pressure, you can control your cholesterol, you can control your obesity, you can control your diabetes with both medications and lifestyle stuff. So that's what they're for. They're for finding the things that you can change. But what they mean for you is the likelihood of having a heart attack. And I bet you that was what happened for those two guys in the office.
Well, I think, again, I can't speak for those two guys in our hypothetical scenario, but I like to know that an important factor is taken into consideration in the decision making. So the fact that because I am Indian or because the patient you're seeing is Indian, that is acknowledged that they're at higher risk. And so you really need to appreciate that when you're deciding about whether you address that risk or not.
That's fine in the UK because it's really important to note that those people, those 1.3% people you just told me I didn't know who were working out who are Indian in the QRisk3 data set, they're Indians in the United Kingdom. Right? They're Indians who are seeing their general practitioner in the UK, in the National Health Service. We've got a very particular way that we do things in the UK. If you're in the UK, it works lovely. But if you're in India, you can't really rely on the QRisk3 score because it's validated in a UK GP practice. Just like in Framingham, it's harder to believe what happens in in an American city is going to apply to Delhi.
Yeah.
So really what we need to see, and we're not going to do it because we're in the UK, but what we really need to see is individualized Indian origin studies that are done on populations in India. And
I guess you're right, because how much can you take my individual risk into consideration? So again, if we look at the UK BioBank, which we said is 500,000 people from all around the UK who have followed up, we know that the people of South Asian origin are at almost twice the risk of people who are Caucasian in that sample. But if you drill down even deeper, actually within that set, the number of Bangladeshis in that group were actually at 3.5 times the risk.
Right.
And so, whether you're from North India, South India, Bangladesh, all of those sub-cohorts can all have different risks. So how personal can you get? It's a tough one.
So, I mean, you've got to remember that the risk factors that cause heart disease in Indians are the same risk factors that cause heart disease in the Western world. It's the same thing, right? It's not like some special thing that's causing it. It's the same biology up to a point. I think you're going to disagree with me, which I love the idea of. I can't wait. But it doesn't mean that just because you're Indian, you can ignore your cholesterol, or just because you're Indian, your blood pressure is not so important, or just because you're Indian, the only thing you need to worry about is your diabetes. All the risk factors cause heart disease. It just, they seem to happen at different rates in different populations. And the other thing to say, we're going to talk about the UK BioBank for the rest of our lives because there's so much great research coming out that's going to inform what we're doing.
Yeah.
But basically, your categorization in the UK BioBank is at the convenience of the researchers, right? So if a researcher wants to do a study and they don't care about Indians versus people from Bangladesh versus Pakistanis, they just want South Asians, then we're all in the same pot, right? We just end up being looked at the same, and then you could draw an inference for South Asians. We know there's enormous genetic heterogeneity in India, loads of different genetic types, lots of different types of people, different diets, different cultures.
Yeah.
The idea that you all end up in one pot as South Asians is a little bit irritating for research, but that's what happens. But then if people are interested in kind of drilling down, like you just said, then it's convenient for them to look at people for different ethnic backgrounds or different country backgrounds, and they'll do that too. So there's going to be loads of stuff from the UK BioBank about ethnicity over the coming decade, I predict, but a lot of it's going to be about the convenience of the researcher, and it's still going to be in the UK. And I think we really need to see things coming out from India. I hope there are projects in India for looking at the similar things, building specific Indian risk scores, which are going to really help Indian cardiologists to work on it. There's probably some work being done in America for Indians in America.
Yeah, let me tell you a bit about that. So first of all, I completely agree with what you're saying about there needs to be more representation of South Asians, Indians, and the rest of the continent in these data sets. So a group from Harvard, Nishant Uppal and Pradeep Natharajan's group, looked at all 310 cardiovascular disease studies, randomized studies.
Right.
They had more than a million people in those studies, and just 3% of them were from South Asia. So
3%.
that representation needs to improve, and it is.
Yeah.
There's a really nicely named study called The Mediators of Atherosclerosis in South Asians Living in America.
Great.
A big mouthful, but it's been shortened to the MASALA study.
Beautiful.
Yeah, great name. And that, again, is looking at exactly this. What are the risk factors in people of South Asian origin that need to be taken into consideration? And already, they've only got 900 people in so far, but they've already found all sorts of really interesting things, like diet matters.
Right.
So, people from South India, actually, the ones who eat pulse-rich diets actually have lower risk than people in North India who eat refined carbs have higher risk. So it really drills down into the nuances of different parts of the country.
Yeah.
Another really interesting thing that's come out of that study is actually people from North India have more hypertension. And whereas people from South India are more likely to have high cholesterol. So the reason I think I'm just teasing some of these points out is I hope that one of the benefits of AI and all of this big data analyses is that we can really personalize these risk scores.
Yeah.
And so we can look at a person and say, okay, this person with all their risk factors, where they're from, where precisely they're from, take that into consideration when we make these decisions.
I hope so too, but everyone thinks AI is going to solve everything. I think good medicine actually can start before the AI revolution. We've been doing it for a while. And I think that's what's happening with those two guys in their cubicles, working presumably in some horrendous high-stress IT environment. I suspect what's happened is that one of them has had a risk calculation that in the UK, we'd say a Q risk score of greater than 10%.
Yeah.
Means that we probably should offer some medications to reduce the risk of heart disease in that individual. And a Q risk score of below that, or a high cholesterol or something that is not so high risk. So that person's blood pressure might have been better, or the cholesterol level might have been a little bit lower, or they may not have had diabetes. Then we can say, well, actually, why don't you try changing your diet? Why don't we try a little bit more exercise? And why don't you try losing a little bit of weight and maybe even reducing the stress in your job if that's possible? I don't think it is. So that you can reduce those risk factors naturally, right? Without the use of medications. I don't like the use of the word naturally, but that's how people view it. But if that doesn't work, then you need to have backup. You need to have medical science backing you up in case you're not able to do that just with lifestyle modifications. So if you do exercise, your blood pressure will come down. If you lose weight, your blood pressure will come down. If you lose weight, your chance of diabetes will reduce. Cholesterol will change a little bit with diet. It's really interesting to hear about that difference across the subcontinent in people with having high and low cholesterol and high or low risks of diabetes and blood pressure based on which bit of India they're from. I think the diet recommendations we frequently make are like, eat like the Italians. I mean, who in Mumbai is eating like an Italian, right? Like, it's good food, Italian food, but it's not Indian food. And the real kind of difference I think I see in Indian and Indian subcontinent diets is the use of ghee. So lots of kind of high intensity fats that just lead to weight gain rather than them being specifically bad for your cholesterol. So you could do those things. And I think that those two guys have probably had a slightly more personalized approach to their healthcare than perhaps they realize, and that's why they've got different outcomes. One of them will have had a slightly higher risk if things have been done right in their clinical practice.
Yeah, I guess the assumption we're making is that they've seen a good doctor like yourself who has really, taken into consideration all these factors that we've spoken about. And I think that's really what you can ask for. And again, I think I want to go back to this idea of patient empowerment, that you should feel comfortable to say, okay, I'm happy to not take a cholesterol medicine, or I'm happy to take a statin, but how have you reached that decision?
Yeah.
You're entitled to know that.
Yeah.
You're entitled to know what risk score has been used, what risk factors have been taken into consideration, and it wasn't just a flip of a coin.
Yeah, and the other thing to say is that often these decisions, like when I make them, and you'll do the same, and actually in the UK it happens a lot, we make those shared decisions with the patient because we're talking about risk, right?
Yeah.
So there are groups of people, I meet patients, and they don't care. They've had their test done. I tell them they've got a risk of heart disease of whatever it is. And they say, that's cool, thanks, doctor. What should I do differently? And I say, you should do these things, maybe take these tablets. They don't want to do that. They're happy with that risk. I find it very, very difficult to understand, but they're happy. They'll take the risk. Okay, if I have a heart attack in the next 10 years, well, my dad had a heart attack when he was 52. What's the big deal? And others really want to maximize their health. They really want to minimize their risk. They want to be in really tight control. So those people we might offer medications to, or we might offer treatments to, we might offer exercise regimes to, that we wouldn't give the kind of average person, because the average person's kind of chilled out about it, but they're really keen on minimizing their risk, living as long as possible, getting the most out of their life as they possibly can, and they want to take medical science along with them. So those people you might offer treatments, even though they don't meet the kind of guideline-directed risk stratifications that GPs in the UK follow. So
personalization.
Right, a personalization with that person's own input, that person's own sense of what they want included in the personalization. It's not just their biology, it's also what they want out of life.
Got it.
So if they want no sad blue faces on that screen, there's loads that we can do to get them there. But if what we want to do to get them there is a bit too much for them, if having an injection of a statin lowering medication twice a week is too much, and for many people it is, then we might accept half a sad smiling face on the screen, right? And that's a personalized thing. You have to talk to the patient about it. And so that's, I think, what's happened with those guys. Like, they will have hopefully had a good conversation with their cardiologist or their general practitioner. And if they couldn't really handle it with their general practitioner, they get a referral on to someone who can. And then they've made those decisions based on that. That's probably what's happened. It's not random.
Great. And I think that's a great note to leave it on.
Nice one.
Thanks.
Great question. See you.